prematurely born, that is at 35 weeks, 1 week old baby presents with jaundice. The mother is a childcare worker with history of fever and rash in the last trimester. The vital signs are heart rate 135 beats per minute, respiratory rate 40, temperature of 98.6. Physical examination reveals jaundice, preachial rash, microcephaly, and hepatomegaly. Lab results show direct bilirubin levels of 5 milligrams per deciliter, alanine aminotransferase 90 international units per ml, platelet count of 80,000 per microliter. There are abnormal findings in cranial ultrasonography. The newborn is suspected of congenital cytomegalovirus infection, which is the best time to obtain the sample to confirm this patient's diagnosis. Again, CMV infection, because it can be transferred to the baby, it becomes very important. CMV, measles, varicella infection. So all these infections, these are quite commonly asked in the MRCOG exam. Make sure you know about them. So CMV infection, when do you think is the best time to obtain the sample? Yes, within the first 3 weeks of life. That is the best time to take the sample. So you can either take a mouth swab or you can take a urine sample, and this should be taken within first 3 weeks of birth. And in case the baby is found to be symptomatic, then you can give ganiciclovir or valganiciclovir. So a pregnant woman reports to the clinic for a routine antenatal checkup. She is diagnosed with gestational diabetes, and her latest fasting plasma glucose levels are 6.5 millimoles per liter. Her pregnancy has complications like macrosomia and hydroamnios. So what is the next best step for this patient? What is the diagnosis in this case? Which is very simple. And her blood glucose levels are 6.5 millimoles per liter. So obviously this is a patient with gestational diabetes and her blood glucose is 6.5 millimoles per liter. So what should be the next best step for this patient? What should you do in this case? Yes, you should start immediate treatment with insulin. That is what is important. It can be with or without metformin, and diet and exercise changes along with it. And this is because, as per the NICE guidelines, if the fasting plasma glucose level is between 6 to 6.9 millimoles per liter, then you need to start insulin therapy immediately. Whether or not you use metformin or not, that's up to you. Because otherwise, the first management plan in cases of gestational diabetes, if the blood glucose levels are not high, is mainly the nutritional therapy and exercise. And you can also start metformin. But insulin is not the first line of treatment in those cases. But if the blood glucose levels are so high, then you have to start with insulin. Next question is, a 30-year-old G2P1 woman presents for a routine prenatal visit at 18 weeks of gestation. Her history reveals her exposure to a close friend who had an illness with fever, swollen lymph nodes, sore throat, and rash about 3 weeks. Lab testing reveals that the patient is positive for CMV infection. So another question on CMV. So sometimes they have a tendency of, picking up one thing and they'll have 3-4 questions related to that. So the patient IgG CMV antibody is negative. What is the next best step for management? So in these cases, you are worried about whether the infection has reached the baby or not. So what do you need to do in this case? I give you a hint that you need to know that infection is not in the baby, because if the infection reaches the baby, it can result in lots of problems for the baby, and the baby may suffer from lots of symptoms. So with serology, you know that the mother is negative, so she doesn't have any immunity against CMV infection. But now you need to know whether it has reached the baby or not. So it is amniocentesis of the amniotic fluid after 20 weeks. Now, why should it be done after 20 weeks? Because after 20 weeks, 90% of amniotic fluid volume will be probably contributed by fetal urine. And fetal urine would probably have, in case the baby has CMV infection, then you will be able to detect virus or the viral genome from the fetal urine sample which is present in the amniotic fluid. So you need to do PCR after 20 weeks. A pregnant woman reports to the clinic and is diagnosed with parvovirus B19. Parvovirus infection is also very important for MRCOG exam. A pregnant woman reports to the clinic and is diagnosed with parvovirus B19 infection. The doctor informs the patient about fetal complications. What gestational age has the highest chance of fetal loss for the mother with parvovirus B19 infection? So during the MRCOG exam, you will have some questions which are very simple in the sense they are the one-lined questions with a definite answer. Like there is no clinical presentation, so you don't have to think. So these questions you do quickly, and maybe you can spend more time on the clinical questions. That is what I suggest to the candidates. So this is usually 9 to 16 weeks of gestation. Infection of the mother appears to be associated with the highest risk of fetal loss between 9 to 16 weeks of pregnancy. And then following this, the risk decreases. So by second half of pregnancy, the risk is quite reduced. And the final 2 months, if the infection occurs, then the risk is almost nil. A 27-year-old primary gravid woman with 32 weeks of gestation presents to the clinic complaining of abdominal distension that she noticed over past 2 weeks. An ultrasound scan shows polyhydramnios with an appropriately grown fetus which has ascites and scalp edema. The woman works as a kindergarten teacher. She denies any recent illness, but some of the children at her school have been sick recently. What is the most likely cause of her fetal findings? What do you think is the fetal diagnosis? Ascites and scalp edema, what do you think the baby has? And she's having polyhydramnios. Non-immune hydrops, yes. And which infection causes non-immune hydrops? Parvovirus, yes. So the answer becomes parvovirus. A pudendal nerve block is given to the patient. Blood comes out on aspiration. Which of the following arteries may be involved here? So if you're giving a pudendal nerve block and there is some blood which is coming out on aspiration, you have probably punctured some vessel. So which vessel is that? Yes, internal pudendal. A 6-year-old girl is brought to the clinic with complaints of rashes on her arms, legs, thighs, and buttocks. Her mother reveals the appearance of a red rash on her cheek 2 days back. She has low-grade fever, rhinorrhea, malaise, and headache 1 week ago. Her elder sister had similar symptoms 2 weeks ago that resolved without treatment. On examination, a lacy reticular erythematous maculopapular rash is found on her extremities. What is the likely diagnosis? What do you think the condition is? Yes, it is erythema infectiosum, which is again caused by parvovirus. And this is the slap cheek appearance and the circumoral pallor, which is there, and red cheek. So these are typical features of a parvovirus infection causing erythema infectiosum, or the Fifth's disease also, what it is known as. Okay, now this is a gram-negative, non-sporing forming, non-motile, encapsulated, non-acid-fast bacillus appearing in form of kidney shaped under the microscope. So this is the appearance under the microscope. This is blue in color, the picture, but this is actually this is gram-negative. So this will be under the microscope, this will appear magenta. Which of the following bacillus has this type of morphology? These are the options. Yes, gonococcus. Now, how do you differentiate between gonococcus and meningitis? Because that is also gram-negative, that is also in pairs. But in that case, it will be like this, a coffee bean appearance, and the ends are not concave like in this case. So here you see there is a kidney kind of appearance, kidney bean kind of appearance, because the ends of the two bacilli, the diplococci, they are concave, like you can see here. These are concave. But here, in case of meningitis, this will be flat. So this is a coffee bean appearance. So you need to be careful, okay, in diagnosing, because the question could have been related to meningitis. Depends on the kind of smear they have given. A 34-year-old woman is planning to conceive a second baby. Her history reveals complication of excessive amount of amniotic fluid in the antenatal period during first pregnancy. The child was born with a defective skull and brain formation and expired soon after birth. What is the prerequisite in preventing the occurrence of such an outcome in future pregnancy? So what do you think the child suffer from? What do you think is the condition? Defective skull, defective brain formation. The mother had hydroamnios. Yes, this is anencephaly. So for prevention of anencephaly, which is a neural tube defect, what do you do? What is the prerequisite in preventing the occurrence of such a condition? Yes, folic acid supplementation. What week of pregnancy does fetal hematopoiesis begin in the liver? This is 5 to 8 weeks. So again, this is initially the hematopoiesis is occurring in the endoderm. And then by 5 to 8 weeks, it shifts into the liver. And following birth, few weeks or in the first 5 to 8 weeks of birth, then it is shifted to the bone marrow. A 17-year-old female reports to the clinic with a complaint of primary amenorrhea. Her ultrasound report reveals 2 aplastic uterine buds on the pelvic side wall in combination with a uterine remnant but have normal ovaries. So her ovaries are normal. The uterus is not well developed. Her FSH range is within normal range. What is the most likely diagnosis? This is quite simple. So what is the likely diagnosis in this case? Yes, MRCOG. I don't think I need to explain it. It's, I think, very apparent that ovaries are there, the uterus is aplastic, the FSH levels are normal. How many weeks during pregnancy does fetal kidney urine production start? So when does the fetal urine production starts? It starts by 9th week of gestation. And by 20 weeks, the fetal urine is making almost 90% of the total volume. So it starts by 9 weeks, but major contribution of amniotic fluid from fetal urine is coming only after 20 weeks. A 4,200 gram baby is delivered with low vacuum suction to a G1 P0 mother. The labor was induced due to decreased fetal tone. Apgar scores were 9 and 9. Moderate shoulder dystocia was also observed. So what is the best step of management? You may require all the above maneuvers because all of them, they are, initially you'll try McRoberts maneuver, you'll try changing her position, you apply suprapubic pressure. If that doesn't work, you may have to go in with the internal pelvic maneuvers, which is the corkscrew maneuver. Shoulder dystocia is their favorite topic, one of their favorite topics for MRCOG. A 25-year-old female patient with thigh soreness visits the clinic. She claims that the pain is located on the inner aspect of the thigh and exercising makes the discomfort worse. She runs 6 days a week because she is a devoted runner. On physical examination, hip abduction and extension cause the patient to wince. Compression of some nerve is suspected. Where is the nerve most likely being compressed? If hip abduction and extension is causing the patient to wince, where do you think is the problem? It's probably the medial aspect. So medial aspect of the thigh, which is the nerve which may be getting compressed? Obturator, yes. The obturator canal is on the medial aspect of the thigh, and that is the reason why she is having the pain. Which of the following nerves has a terminal branch which is called as the dorsal nerve? Branches of, I'm giving you the answer only. Branches of pudendal nerve, they are most important again for MRCOG. So now you guessed it right that the answer is pudendal nerve. A 63-year-old female complains of stomach heaviness from 20 days along with bloating, lethargy, and frequent and urgent urination. Diabetes mellitus has previously affected her. An enlarged non-tender abdomen is seen on physical examination, and a non-tender adnexal mass is visible in the left pelvic area. Laboratory tests reveal glycosylated hemoglobin levels of 7.2% and CA-125 levels of 25 units per ml. A multilocular cystic adnexal mass with nodularity measuring 8.5 centimeters to 4.5 centimeters is shown on the ultrasound report. What is the most likely diagnosis? So if it is a multilocular cystic adnexal mass, it's most likely, and she's also having bloating, I think. she is having bloating, so probably there is some ascites also present. So this points towards a malignancy, and it's most likely. So most of the candidates are answering mucinous carcinoma. Why mucinous carcinoma? Why not serous carcinoma? Please answer on chat. Why do you think it is mucinous carcinoma? Yes, CA125 is normal. How much is the normal levels of CA125? 0 to 30 units per ml. Plus, is there some, yes, no, wait, multilocular means it could be malignancy. The size is also very big. In comparison to a serous carcinoma, the size of this tumor is also very big. It is 8.5 to 4.5. Plus, it has nodules, it has nodularity, so probably that is related to mucin accumulation.